Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency.
Today's guest is Hunter Hayes. No, he is not the country star singer, but he is a star in and of itself. Hunter was a competitive springboard diver from the age of 6 through his undergraduation. He had several internship jobs before consulting, including living in China and supporting an agency in the textile industry, professional photographer's aid, selling home security systems door to door, and his family owned and operated local newspaper for 6 generations. So he knows his way around newspaper companies. He also kind of stumbled into the healthcare career, being a mathematics major in an undergrad, then getting his MBA directly after to buy himself some time to figure out what he really wanted to do. He got lucky getting an internship in a boutique consulting firm in Louisville, Kentucky, and then kept following areas that just felt right to him. He followed his heart. Imagine that. He ended up with a bachelor's and master's in mathematics with a minor in computer science from Center College in Danville, Kentucky. Since then, he has become a healthcare consultant and has a resume that is full of a plethora of skills. Some of his skills are facilitating executive leadership team meetings to set strategic plan for over 3,000 physicians employed in medical groups. He designed a standardized physician compensation plan. He helped design and define a system-wide oncology patient navigation program to provide greater access to care and frictionless experience. He developed he developed key patient intervention points along the patient's care journey, including standard operating procedures and documentation practices within Epic. He piloted the program with 4 disease sites and developed a comprehensive business plan to scale the program, including ROI impact, staffing projections, change management plan, and organizational structure requirements. He created a strategy for major hospital buyout while helping to consolidate care. He researched hospital systems to develop potential partners between regions. He's performed due diligence analysis of private practice. He's oversaw physician manpower development plan for hospitals. He studied the future of healthcare benefits relating to recent reforms, and so much more. Please help me welcome Hunter Hayes. Hunter, thank you so much for joining us today on the podcast. It was interesting. I met Hunter because him and his wife were patients, or his wife was a patient that I scanned, and we connected on a neat level and had some things in common. But Hunter was willing to come and share his expertise in this area of corporate healthcare, which I think is a topic that, as a ultrasound tech, we don't really have an idea of what that looks like, or what kind of struggles or ideas or things that corporate healthcare really struggles with or is looking to solve. because we're just trying to solve our own issues, right? In this small little world. And so I thought it'd be helpful to have Hunter come on and talk about his business and what he does and the corporate side of medical. Welcome,
Yeah,
Hunter.
thanks for having me, Debbie. This is my pleasure to join. It's I love talking about my career because I find it fascinating how I even stumbled into it, and candidly, it's kind of difficult to explain too to a lot of people when they ask what I do. So a little bit about myself.
Yeah.
I'm a partner at a national healthcare consulting firm called the TARDIS Group. I've been doing healthcare consulting specifically in for employed physician groups. It's kind of where my focus area is. Been doing it for I'm losing count now. I'm going past 15 years, maybe 16 years or so. And like I said, I stumbled into this. I was a mathematics major in undergrad with a computer science minor. I bought myself some time going to an MBA program right out of undergrad because I did not know what I wanted to do. Um, Candidly, didn't even know like healthcare as going into as an industry, like wasn't even on my radar. Uh, I thought I wanted to be maybe an actuary because that's what a lot of people do with a math degree. They
Ah,
go in
yeah.
and do probability theories. And
Right.
I uh, I remember I had an interview with Humana and in Louisville, Kentucky. I'm from Kentucky originally, born and raised, and had an interview there to do an actuary internship, and thought I was going to get it. Didn't get it, and quickly learned this like the type of people that are in that the personality style just didn't fit what I liked. And I ended up selling home security systems door to door that summer because I needed a job.
Yeah. Yeah.
Um, so my job path has taken a lot of interesting twists and turns before I finally landed at a career consulting position.
Yeah, which I love because we were talking earlier. I have adult children now, and I think we have to give ourselves grace when we're trying to figure out what do we want to do in life, right? And a lot of us landed in ultrasound in some way, shape, or form. Either it's being a technologist, either the applications, teaching, however it may land. But at some point in time, sometimes you think, oh, we need to reinvent ourselves, or we need to kind of open our mind or ideas up to other opportunities. And I just thought your job was super fascinating. I could just dive in and really probably have a lot of fun in that area and never thought of it as an occupation, right? I didn't even know that it was a need or that there's companies out there. But more than
Yeah,
anything, for us to understand, um, the struggles of corporate healthcare, right?
sure.
The kind of things that corporate is like needing people to help them with, right? So,
Yeah,
and I think all your background jobs and have all kind of fed into you being successful where you're at, right? Your door-to-door sales, I'm sure gave you skills that you use now, right? And what you do. So despite the fact that we flounder and do all these little odds and end things and whatever, I think it all kind of comes together to some extent in certain ways, right? Like it
totally. And
did, like it did for you.
yeah, yeah, and Debbie, what I found so fascinating in our conversation while you were, you know, looking at images of my future daughter and everything, I thought what I found was like really cool is, or just like fascinating with what you're doing with the podcast and um, trying to have this voice to elevate ultrasound and the stenographers more broadly, and some things that I see and some of the projects that I've been on is a lot of people get into it. I've got family members and friends who like went into nursing careers or went into like, you get into healthcare because you want to take care of patients. And a lot of the things that I see, you could even go down to a scheduling agent in a call center that's trying to get an appointment for an ultrasound or to meet up to have an appointment with a doctor. And I go into places like that and I see like there's no career progression. You see people that are just kind of sitting there stagnant. There's and I don't think any human generally wants to be stagnant. I
Right.
think every human has this desire to elevate themselves, learn, grow. Of course, you get better. The longer you do something, you should get better at doing it, more proficient, efficient. But,
Right.
you know, I think everyone has this desire to climb a ladder. And at least in my role as a consultant, there is no different from a law firm or accounting firm where you start at a junior level, you work your way up to middle management, and then eventually up to partner where I'm at now. And I still have a couple more steps ahead of me to to get into more leadership positions, but it's naturally there. But in the role of an ultrasound technician or sonographer or a nurse or a scheduling agent, like it's not as clear and transparent. Um, and one specific project I worked on was for a top tier oncology, NCI Cancer Center, and it was developing an oncology nurse navigation program. And one aspect of it was it wasn't just about the patient journey. I mean, the whole part of it was really about the patient journey, but one of the side effects to it was we actually created this career ladder for oncology nurses. And like to get this navigation position, you had to be bachelor and master's trained. You had to be in, you know, have experience for so many years, and even better if you were specific to a various disease type. And so, like creating this position and creating a program, it actually introduced a career ladder for nurses. Um, so I find that fascinating that the work did not just it clearly we impacted the patients. Like every single new cancer diagnosis had a dedicated individual to walk them through this very life-threatening, complex disease. Um, they had that person, but then the impact to the employees was just as great because now they have something more fulfilling in their job and their role. And when I came in, hired in as the consultant, they're asking me for things like, what do other organizations do? How do nurse navigation programs work? I mean, I had to write job descriptions. I was writing standard operating procedures. I got far into
Yeah.
uh, EMRs and just like learning how you document different things and how that then flows to a doctor back to the patient. Like we got into every aspect of it, but that's what the or my client was asking us to do was help us figure this out, create the program, pilot it, and then after that I had a big transition plan, and they scaled it, implemented it throughout all their disease groups. So that's just a flavor of the types of projects that I get the opportunity to work on.
Which is amazing, right? And that's one of my desires, right? Is to show ultrasound techs, 30 years ago when I started. I mean, you got out of school and you became an ultrasound tech, and that was it, right? The only other place to go was middle management if you wanted that. Wasn't sure that I wanted that at the time. Um, but when someone you had to wait for someone to die or retire or something to, and then 20 people applied for middle management, Now there's so many more opportunities, and with our profession going the way it's going, I think I'm hoping to create more of that ladder, right? To give us some kind
Yeah.
of a ladder that, okay, when you come out of school, you can do this, and these are your opportunities, and you can get a bachelor's, you can get a master's, and really make an impact. Because I certainly think we're just as smart as nurses or any others field, you know. A lot of our training is just very on our own, you know, which is makes it a little bit more challenging for us, but we do it. We always step up to the plate to get the job done. And so there's so many of us that have voices and have things to give. And so I was hoping this platform would be part of that. So
Yeah.
I'm glad that our professions kind of cross this way, and letting people know that there's people out there willing to help hospitals do this, right? And so being able to connect, you know, maybe you're in a hospital and you want there to be more of a program, and you can reach out to Hunter and uh see where it might take you. I don't know. But
Yeah. Yeah.
a few more of you've got such long laundry list of all these amazing things that you've helped medical groups and doctors and things do. Compensation plans and ambulatory scheduling and workflows. Tell us about a few without using,
Yeah,
you
yeah,
know.
yeah, yeah. One of the things, Debbie, that I remember chatting with you about is we talked about the role of advanced practitioners, and like I had no line of sight too that I believe stenographers there's a pathway now towards becoming more of an advanced practitioner, being an actual billable resource to an organization. And I have done several projects that it was solely focused on the role of APPs in an organization at a macro level and at individual like specialties. There was another client that I had where um, very intentional. And I believe this is something in the future that is coming. It's inevitable. All the research and all of the data points show that there is a physician shortage that is happening now. It's only going to get worse.
Yes.
Well, there's a big solution to that, and one of the big solutions is advanced practitioners. Um, and it's so fascinating, even talking to my wife's midwife more recently, because we were back and forth. Do we use an OB? Do we go to a midwife? Pros and cons to both, and
Right.
nothing against or for either one. But I will say, like we were talking to our midwife, we've had a really good experience with is you have to realize that the background in a midwife versus the background in a physician is the orientation starts with the patient from a midwife because you're typically coming from that patient facing first career path and that orientation versus a physician's going right into med school. They're learning all about the anatomy. They're the ones who are trying to call the shots and make decisions around diagnoses. That's first, and then patients second. It's just how they grew and learned, and
How it's
and and
structured
that
is
it's
how.
how it's structured. And a lot of people that I talk to, you typically see advanced practitioners have better bedside manners. Their clinics are still very research based. They spend more time with the patients. Um, and again, not you have to have physicians. I'm not saying you can swap one out, but what I am saying is that the future is showing and demonstrating in the organizations from a corporate lens, the ones who are putting more focus and intentionality around um, harnessing the power of APPs and figuring out care models and team-based care approaches where you're introducing that as and the physician is more of kind of the leader or the manager oversight of that, but the APPs are doing more of the work and you're going back and forth. The physician gets highly complex things, whereas the APPs can do more of the call them bread and butter or
Right, right,
um,
right,
some of those cases, but um, some of those things that's how you solve for problems like physician burnout, like
right.
uh, the physician shortage that's coming. And like this is what I love is fascinating about if ultrasound and more broadly not radiation, radiology technician like jobs are elevating into similar type roles. It's coming, right? Like it's the market's going to mandate it because that's the only way we can take care of patients.
Right. Right. And as a traveling ultrasound tech, I see it all over the place, right? Well, we can't do this much. We can't do fetal echoes because we don't have the manpower to do the regular work. We don't have physicians to be able to keep up with everything, right? Um, and physicians are being creative and working offline and working for other remote and other sites. And so it makes the in clinic physician puts a lot of stress on the in clinic physician. So I think there's a big hole that ultrasound is going to be able to fill. And to have someone say from the corporate end, yes, there is a shortage, and yes, there is going to be a need. So get ready, you know,
Yeah,
get ready. So, um, I'm
And
excited about where ultrasound might be taking us and going. And it's exciting to hear from the corporate end that, that's a possibility and it's soon to come.
and Debbie, one of the just like a philosophy that not only believe in, but I'm also preaching to my clients as well. I'm wrapping up a client up in the Northeast right now, where one of they're asking us to help them integrate two medical groups. They're already employed by the same parent group, parent company, and they're one of the asks was like, what's the right leadership structure? You think about, when you think about on the corporate side, like who's the CEO, president, who's all the VPs, and like what's the tree kind of look like underneath it?
Right.
They asked us to do that for like if we were to merge these two groups together, what's that look like? And one of the philosophies and kind of underlying principles that we are preaching to them is administrators report to administrators, physicians report to physicians, APPs report to APPs. So naturally already creating this hierarchy of leadership, right? So that I think about ultrasound technicians probably have a standard of care. I have no idea what it is, by the way, but I'm sure there's like I'm sure there's like some sort of standard that in your profession you are supposed to follow.
Absolutely.
And who is the person that's helping you if you're a brand new technician coming in? Who's helping you adhere to those standards? Who's helping you, deploy uh, those resources across your network appropriately? Like the person that's directing that traffic should be kind of like your own person, right? In collaboration with the administrator, with the physician leader. But it's generally just a principle that we're trying to introduce. Um, Nurses have it. Nurses report to nurses, nursing managers. Nursing managers ultimately report up to directors, who then report up to a chief nursing officer.
Right. Yeah, and in ultrasound, we report to an office manager who isn't a nurse or an ultrasound tech, typically. And oftentimes, what I found is, unfortunately, um, that if you're a really good ultrasound tech, then they want you to be the lead tech, which is awesome. But being a lead technologist and a good technologist is a very different skill set than management, right?
Totally.
And so you've got this really good technologist with bad people skills, or we're reporting to a nurse who doesn't really
Yeah.
understand anything about what we're doing, or different things like that. So I think there's huge amounts of growth for just learning new skills all the time, not just ultrasound, people skills,
Yeah.
management skills, and having that structure in place, like you had said, administrators to administrators, physicians to physicians. We just don't see that very often. And so I think that's an amazing structure that you put in place, because it really gives more credibility, and you have someone really giving you a voice to what your profession is or your specialty is. So I appreciate that model that you're pushing forward. Unfortunately, it's not everywhere. Not yet.
No, no, not
Right?
yet, but it is something that I would argue it's a coming attraction over the next decade. Um, and let me throw another kind of analogy to what you just said about the lead tech and versus, having the right people skills. I think about I do a lot of work in just physician leadership coaching as well.
Yeah.
Even though I'm not a physician, we've got great physician partners and senior partners at my firm that I partner with. Like I work with them almost like a dyad would.
Sure.
Um, and I remember he talks about this. It's like there's two different ways of kind of leadership credibility in the physician world. And it makes a lot of sense when you think about academic physicians in particular.
Right.
You gain credibility kind of through two ways. One way is like the person who's doing all the research, writing all the papers,
Right.
you know, has, and has like great clinical quality scores and is like the best of the best, right?
Published. Yeah, it has multiple
Exactly.
published. Yes.
I think about like if I had to have open heart surgery, like I'm gonna go pick the surgeon that has the best outcomes, who's got publishings everywhere. Like that's who I want cracking me open.
Right.
Um, on the flip side is um, that same physician may not be the best person who wields the power of influence. That may other physicians respect that individual because of their quality, but that individual may not have all those leadership type qualities. And I see this a lot too. You start to see physicians that are rising up into CEO roles or top leadership positions. They're the kind of physicians that are coming from the other spectrum. They've earned respect through um, kind of that leadership corporate
Mm-hmm.
lens.
Mm-hmm.
They have respect from their peers because they have the MD after their name, and they go to bat for their docs. They are the voice of those docs, and they are respected because of that way. So there's you can think of that as being two different pathways of leadership and credibility. Both neither are wrong, neither are right. It's just I would encourage your listeners here that you have to think about those things. Like you can, if you want to be the best tech there possibly is, you need to do research. You need to crank out more volume and see the cases and just get better at it. But if you want to do leadership, the other pathway, you need to start thinking about the soft skills, take some leadership courses, do leadership classes, um, learn how to earn the respect and the voice of your peers and companions uh, to be that spokesperson for them. That will get you a different level of credibility that rises you up into people leadership, people management positions.
Yeah, that's a great point. I think, yeah, to a certain extent, we do have some leadership skills that we use with our patients every day as we're leading them
Sure.
out the exam and leading them along the way, right? We're having to manage emotions, and expectations, right? So sometimes those skills can transfer to leadership to some extent and be built upon, right?
Yeah.
But I think you're right. I think there might be a time in your career where you're really, putting in the time and doing as many scans as you can, and you decide to publish, article, which I highly recommend because I think it's an interesting dynamic and way that hospitals do that. And there's a lot to be learned that way as well, right? It gives you some credibility for speaking to other groups as well. But like you said, having the gift of influence is really a gift, and
Yeah.
it's especially a very special skill to have, um, to help move people forward that might not necessarily want to be moved forward, right? So, yeah, I think there are two great dynamic avenues that people can pursue and think about, as far as the future for their career a lot. Um, and like you said, I also appreciate what you said about the midwives learning from the hands-on, right? They're much more hands-on. They learn the touch, the feel, what things feel like, look like before, and then do the book work on the back end kind of thing. Whereas the physicians, just to circle back to that, I know I'm kind of jumping around a little bit, but
Oh, yeah.
learn the book work and then so many times teaching residents and interns, we're having to teach them the softer skills of, okay, this is what she's going through, and we can't just walk into the room and blow her hair back. Like you gotta come walking in, asking how everybody's doing and get the feel of the room and be able to assess that pretty quickly, right? So like you said, nothing wrong with either pathway. One's a softer skill, like you mentioned, one's a little bit more academic, but both are successful and both can be used. And I think this is interesting across different professions. Like I'm in maternal fetal medicine, right? And we use a lot of soft skills, and a lot of our physicians have to be very academic, but also have a good bedside manner, right? Um, However, in other specialties, neurosurgeon, there's not a lot of soft skill there, you know? And
Yeah,
um, so, you know, I think it's interesting the different specialties that you're in and how
yeah.
different, right?
I,
Um,
I joke with a lot of my colleagues too that I got colleagues who do nothing but perioperative OR throughput services, and some colleagues that do nothing but cancer work, and others that do, you can subspecialize in consulting kind of anywhere you want to, because there's usually a need for that expertise. And it's fun to go down the kind of list of specialties and kind of their personality types, right? Like you see a lot of surgical specialties who are it's broke, I'm gonna come in and fix it mentality. You see anybody that's in more of the ologies, right? They're a little bit more cerebral in their thinking, kind of their personality type. And so I think I find it hilarious, and I find it largely to be true when I have very like specific projects where I'm interacting with a very specific specialty type. I've been doing this work long enough. I kind of know what I'm walking into usually in terms of what kind of personality I may be interacting with. So I know how to choose my words appropriately most times. So yeah, it is interesting.
so I noticed on your lengthy resume here of some of the things that you have helped to um, develop systems of potential partnerships within regions. So
Mhm.
tell me a little bit more about that.
Yeah, there's a few clients that kind of come to mind. One of them one of them spanned an entire state. I'm not going to say a state because it'll easily give the client away, but there was
Yeah,
there was um there was a large organization had just acquired the assets of another large organization. We're talking about like a national two organizations. One of them acquired the other assets within the state. We're talking about lots and lots of hospitals and lots of employed docs, kind of all everything's getting shuffled around. Meanwhile, they're also losing hundreds of millions of dollars, like they're hemorrhaging cash. And in the midst of it, they're also like acquiring another hospital. So like all of this was going down, and like you can imagine trying to figure out this. I mean, this is a really hard Rubik's cube that we're trying to solve for,
yeah.
right?
And
Um,
it's not eight turns and you figure it out.
right, yeah, and it's like their medical group was very early forming. The leader of that medical group had only been in place for not even a year when we got there, and was absorbing employed physicians kind of in the north part of the state, the west, the east, the middle, the south. Like every one of these locations um, they had their own cultures, and some of them were like in some areas they had a bunch of specialists, others they used private practice physicians, other areas actually had private equity backed physicians. So they're all like incentivized differently. They have different goals in mind. They all operate slightly different. So it's like, how do you go tackle this? Like I scratched my head. I didn't have much time to scratch my head because we had to get some answers to the client pretty quickly.
Right.
Um, but it was a lot to handle, and we did some really cool things by looking at service lines and saying, and again, I'm obviously looking at this at a very macro level of, where are patients originating from. Um, we did a really interesting study with them about just their open heart cases. They had open heart capability at like 6 locations, and eventually what we taught where we helped steer them is like, let's bring all of these cardiac surgeons and cardiologists, all of their heart and vascular docs leaders across the different geographies together and say, listen, you're not hitting volumes in these locations to make meaningful changes or make meaning, like you're not going to be able to ever hit your quality scores on this. Like we had to approach it from a patient outcomes and quality lens. We need to help generate some sort of a hub and spoke type model where you've got the right deployment of the right specialties in the right locations, and we're going to send the open heart complex stuff to these two locations. So we had to do this whole like reorientation of how their physicians were deployed, the capabilities at these various hospitals. I remember one of the hospitals, like we got to we can't hire a neurosurgeon. I mean, he's in the middle of nowhere, and they're paying for locums to come in. And it's like, you know what? One of your best, and they're doing that for having a level 3 trauma designation.
Okay.
Well, you know what? Sometimes your best trauma strategy can be to put a helicopter pad on the top and send them down to another location.
Yes.
You have to balance this fiscal responsibility
Right.
with what's the right thing for the patient. Yeah, of course, if I'm really sick and I live in that place, of course I'd like to be able to go somewhere close by. But if you're in a very rural state,
Right.
like these are your best options. And like we had to deal with maternity care deserts in this situation too. Like we had to recommend shutting down OB services in in one of the locations because they were like right on the tip of this. I think the number was like less than 200 births in this location. It might have been less than 100. I can't remember what this figure was, but it was going to require patients in this community to have to drive 30, 45 minutes south to get there to do their deliveries. So
Wow.
like, how do you solve for that problem?
Right.
It was,
Yeah, I talked to a lot of colleagues who are like, we need more education in the rural area, right? Like I've worked in rural communities and oh my gosh, you get some strange stuff,
yeah,
and you're right. You can't hire for a whole department just to get a level 3 certification, but you can put a helicopter pad, which is probably better care for the patient, right? Um, because if you don't see it often, you don't become that proficient with it, right? So I think that's amazing that you could look at it that way and help to readjust and
and Debbie, what's so hard about this too, and I just want to acknowledge that, particularly from a ultrasound technician lens, where your day-to-day job is going in and out of clinic, and you're just kind of doing the same, like not doing the same, you're seeing a lot of different things, but like that's your focus. And when there are people like myself or like corporate that are looking at these macro level things, like coming to a decision to close this service was not an easy one
oh
by
no,
any
never.
means.
Right, right.
It's never an easy situation. And like, we know that like having to have that conversation with the individuals that are getting impacted, that have those jobs, that live in that community. Um, I'm not certain if there were ultrasound techs in this. I'm sure there were
Right.
not a ton of them, but like if we're moving
Typically
this,
not.
it's
That probably wouldn't have impacted them as much, ultrasound, because they have plenty of other work on other ends, right? You're probably
right.
true. One thing off my to-do list,
Yeah.
right? But
But but
yeah,
but
but it
that's the
doesn't have.
struggle and the balance
Yeah.
that I think I have a luxury in that I say this too because even when I'm working with executive leaders, I can have a day for myself where I'm going into a clinic doing observations and looking at patient flow through a clinic, talking to the check-in staff, talking to all the clinic support staff in the back, talking to the docs. And in the next hour, I can have an executive steering committee where I'm talking to the entire C-suite of the health system in
Yeah.
the exact same day. That's not an uncommon day for me.
Right. Right.
And neither one of those groups have great line of sight to what the other actually do.
Right. Right.
Um,
Yeah.
and it's rare. There's some really good organizations out there that I think do a better job of ensuring executive leaders do, quarterly rounding through clinics or through the hospital, just to have more of a presence and actually talking to the frontline staff. That's a I think that's a core tenet to a really good culture of an organization where you see that type of thing happening, but it's rare. Um,
It is rare.
Sadly.
Yeah, but I will tell you, I think it a little bit goes a long way. There's a few instances in my career where I worked in a rural hospital, and the hospital had some kind of employee picnic or something. I don't know. And the president of the hospital showed up and was talking to one of my coworkers. I wasn't there. She was there, and she was talking about, I don't know, a patient or a brother or somebody who was struggling on illness, or she was doing a fundraiser or something like that. And the president had donated some money, took some money out of his wallet and gave it to her for this fundraiser thing. And she was like, oh my God, like he could do no wrong, like that he would care enough to, and I'm like, well, they're human too, like,
They
um,
put their pants on the same way we do every day.
yeah, absolutely. But it went such a long way. Another colleague of mine, um, her husband actually was one of the CEOs for the veterans hospitals. Um, And that's exactly what he did. He would schedule in his schedule one day where he would go to a certain department, and he went down to surgery and was mopping floors with these girls, and they were telling him how to do it and what he couldn't.
I love that
Yeah,
undercover boss situation.
yeah. But you know what? He was successful everywhere he went.
Yeah,
He was the top of the line, and people wanted him to come to there because he got people um behind him, you know?
yeah,
And
I
so I think that's a really huge strategic move for leadership,
yeah.
right?
I
And
also think the inverse can be true too. You hear a lot about people that are, um, going on strike and people that are complaining about executive leaders making too much money. I just want to remind people too that I was talking to my wife about this on a walk last night. He's like, I have zero desire to ever be a CEO because of the amount of pressure, the amount of public scrutiny that you face, like the amount, and you don't have anybody to look up to when you're the top of the food chain. You're the head leader.
right,
Just like reminding people, like, what if you were in their shoes? Like, have some empathy if you were in their shoes and had to make all of these complex decisions, like the ones I've just laid out about shutting down places or changing services. Like, you're moving a lot of people's cheese. Like, if you were the person moving all that cheese, uh, I think you probably deserve to get paid a little bit more money. But it's like I don't want to be that person under that scrutiny because it is
right.
is a heavy burden to bear.
Yes,
So, like, reminder that executives should be on the front line talking to these staff and doing all the things you said. But if you're complaining about this other thing, just remember, like, if you were in that position, do you think you would do any better? Do you
right.
think you actually have the leadership acumen to to guide and influence people and make some really hard decisions?
Yeah.
Probably not.
And the decisions you make huge impacts, right?
Yeah.
Good or for the bad, right? So you don't have a large margin of error in
No.
in that position, right? So, and like you said, it's a lonely road too. Like your margin of error is small, and no one's walked that road before except you right now.
Yeah.
I agree. I used to tell my kids, don't cast the stone until you've walked in their shoes, like,
Everybody could use a good, healthy dose of empathy.
yes, absolutely. Absolutely. Well, I'm sure there's so much more that we could talk about. Like, I've got questions kind of bouncing all over my head.
Fire away if you want to do a quick rapid hit. I mean, I love talking about I find my career and job like fascinating. I mean, Debbie, when we started this, like I have a hard time explaining what I do. And
Yeah.
it's
Why?
I mean, maybe in this kind of hour that we've gotten to, you know, get to know each other better, like uh maybe you understand a little bit of what I do, but it's
Yeah.
not like I just do one thing because
Right.
like I get a lot of complex questions. It's like, hey, what do other people in the industry do? And I'm just like, I don't know. Let me go ask or go talk, or I'll help you figure it out.
That awesome. Yeah, I love that. Well, tell us more about the physician structure. I think you've done that a few times, it looks like, and how you put their pay and benefit structure kind of together. Describe to us a little bit about that.
Oh man, this has been uh, it, definitely you're asking because I've been in a lot of meetings just today about this actually, so it is very top of mind. Um, this is actually how I got my career started too. In the first 2 years as like a junior level analyst at a small uh, boutique consulting firm in Kentucky. I was doing a lot of fair market value assessments of physician or of organizations that are either acquiring physician practices or they were trying to revamp their physician compensation models and plans. And I don't know if you or how many people actually know what a WRVU is. It is a
I have no
and
idea.
it's called a work relative value unit is what it stands for. And
Okay.
it's fascinating too that when physicians are in training and going through school and the academic side before they actually become, out on their own seeing patients, they don't know what this is either, but it's a measuring stick. It is a widget, if you will.
Okay.
Um, if you think about a factory generating widgets. This is what a work RVU is, but translated into doctor and APPs. So the way that the plans typically work is there are benchmark tables and studies out there. There's a bunch of different surveys out there based off your specialty, based whether you're a community or academic practice, kind of the type of practice you're in, pediatric subspecialties. Like there's all these surveys out there and all of them are surveys to quantify these WRVU widgets. And so there is percentiles of how much you should be able to produce.
Okay.
And so every time a physician sees a patient or does a case in the OR,
Right.
does a consult on the inpatient side, that generates a code, a CPT code. The CPT code is bumped up against a table that Medicare produces every year that basically says this code dictates this many work RVUs. So, like,
Okay.
I'll say like a 99213 is an established patient visit that's coming in, and I think it's like 0.98 of a work RVU. So I don't know how all the math works. I just know that there's tables you can go look up and do this.
Right.
And so physician compensation structures essentially follow, they're going to say, here's how many work RVUs you should produce in a year. We're going to set a performance target for you to hit that. And if you hit that, we're going to pay you a bonus on top of that. So
Okay.
in a nutshell, like that's how they're set up. They can get overly complex with like different tiers of hitting work RVUs.
Right.
And that's usually like the predominant structure for
Okay.
how you pay physicians. And there's also a corollary compensation benchmark table too. So like 50th percentile pay for 50th percentile productivity. Um, where things can get really complex is if you are going really high and you're going above 75th percentile, those can trip things that legal has to get involved and do fair market value assessments to say, are we paying this person? It can look like you're paying for referrals, which is a big no-no, violates Stark laws,
Okay.
anti-kickback laws.
Right.
Um, or if you're overpaying for underproducing, that can trigger things. So like a good comp plan tries to keep those things in line with one another.
Okay.
And then you have other incentive options for quality outcomes, uh, patient experience scores. I see a lot of that happening. Um, based after you go see your physician, you can get a survey that comes to you, and you do the star ratings and stuff.
Right.
Like
Right.
physicians can be compensated based on that feedback as well. So a lot of different levers you can pull, and they can get pretty complex. Um, Usually, where I'm at now in my career, instead of doing the fair market values for just like one or two docs here and there, my current project is looking more holistically, where you had all of these private practice docs coming into this organization getting employed, and there's all these one-off deals happening left and right. And so nothing is aligned. And like we're coming in and saying, okay, we're going to set kind of some philosophies, some guiding principles, set targets here, and try to get everybody on the same contract and try to get everybody kind of marching towards the same strategic goals that the system wants them to achieve.
Okay.
So we're looking at like maybe somewhere near 1,000 employed physicians on this one that this new contracts, all these contracts would impact. Kind of a middle size, slightly large but middle size organization. But yeah, in a nutshell, that's how competent. And I do believe APPs are moving in that direction. Right now, most of what we see, they're full salaried with not a lot of incentive structure in there.
Right.
They're in this like middle. Are you a nurse or are you a doctor? No, you're like right in between. So
Right.
sometimes they're just salaried. You do once you start to have more of an independent practice, it makes sense to start to go onto some sort of a productivity incentive based compensation model.
Right. Which some of the APPs or advanced practice sonographers are. I know one of, I believe she's in Texas, possibly. She gets a base pay and then she gets paid more per how many she does, right? Or how many she's able to read. So it's definitely more like a physician's pay scale, I
Yeah.
would imagine. But is there any way that you can, so that's interesting that you say it that way. Is there any way that you can compare the medical field to, say, um, their pay structure according to, like, I have friends who are, I guess attorneys are somewhat paid similar to medical physicians,
Yeah.
but like doctor or architects or engineers or like some other
Yeah.
business realm, like they get bonuses at the end of the year and they when they're just a little architect right out of school sometimes, and their
Yeah. Yeah.
pay is 4 or 5% a year as opposed to um
Yeah.
our 2% in medicine, right? That's just like standard straight across the board. That's what you get,
Yeah.
so can
I
you speak to any of that at all?
I'll attempt to, because I think that maybe a corollary could be um, lawyers, accountants, even consultants. Like one of our measuring sticks that like how productive are we or billable hours.
Right.
And a lot of when you're I don't know, I can't speak to architectures if that's how if they work off billable hour structures as well, but I
They,
know
they do.
like when you think about a lawyer, you're thinking about, oh, I got this, I'm hiring this lawyer, you're paying them by the minute, and they like, or by the every 15 minute or by the hour type of mentality. um a lot of times, I know this was very true at my previous firm, that my how productive and how billable I was through a year definitely dictated my own bonus. And I'm pretty sure other firms like that is equitable. So, if I'm a full-time employee, I work 2,080 hours in a year, give or take. Um, and I have a target to be 80% productive doing nothing but client facing billable type work. And it does this is directly translated into particularly physician comp, because when I go do scheduling optimization work and like doing template work, one of the big things we talk about is what is your patient facing hours every single week? How many patient facing hours do you have on your template to be able to schedule, directly correlated to your bonus? Because if you're seeing patients in theory for that like 36 patient contact hours, you should meet and exceed your bonus targets. If you're seeing less than that, maybe you don't make your bonus. So maybe that's the closest I could correlate it to. Once you get into like private practice, or once you start to have like business ownership and you start to get into like where I'm at now as a partner,
Mhm.
uh, your bonuses can start to be structured more on sales, more on how well the company does at the end of the year. You know, if the company makes money as a whole, then I think of that more as like it's like a group bonus instead of an individual bonus.
Right,
I'm incentivized to help grow the company and help be profitable.
right, right,
Um, I don't have as much control of that. It's like me collectively working with my other partner and senior partner peers to collectively grow the business.
right,
And if we do well, I get a bonus. It's just a different flavor of bonus.
right, right. Interesting. Yeah, I it it just seems like my friends who are out in the business world have a little bit more room for growth financially than I've worked with nurses who haven't had a pay raise in 5 or 6 years when I worked in Minnesota. Um,
Yeah.
and so what keeps that cap on the lower income people versus, and I just the other day, a doctor came back from a meeting. She had to go to a meeting. She came back, she goes, "Oh, it's the same old thing. They want us to do more and pay us less." So, I guess some of that could be perspective, right? And certainly doctors are not business people, right? That's the other thing is, you go to school to be a doctor and you become a doctor, but learning how the business works is a totally different skill as well. So, um,
Yeah. And you start to introduce you know, the, I mean, it's true. You start all the reimbursement rates if they're going down, and like how, like, of course, people's pay, if reimbursement rates are going to go down, then pay's also going to go down. Like those things are correlated with one another. So there is a lot of validity out there. I've got a neurosurgeon friend on the East Coast that was in private practice for a long time and made a ton more money 15 years ago than he could ever possibly make now, and he's working harder now than he was 15 years ago.
right.
Right. It's interesting too, where I'm working on a proposal right now of, you'll probably enjoy this with a maternal fetal medicine background. It is a reproductive endocrinology and infertility clinic.
Yeah.
And you see a lot of groups that are private equities getting involved because guess what? It's a cash business for the most part. You can
Right.
make a lot of money.
Right. Right.
And you start to see the employed groups are getting upset because they're like, all my colleagues are making so much more money than I do. The
Mhm.
work RVU model I just talked about doesn't exist
Right.
because
Right.
it's a relatively it's a pretty new service offering. There's not a ton of research out there yet about it. So it's really interesting when you start to see these up and coming like new service offerings as medicine is evolving. That's where you see private equity get involved. That's where you see physicians being able to make more money on their own private practice and learn how to be business people because they can, because it's a cash business. So, um, and the proposal, I'm working on a proposal right now that is to go in and evaluate that. How do you structure the right compensation for these physicians that are doing this? How do you attract physicians because they've got some doctors that are retiring? Um, and they're in a hyper competitive market where there's private equity and other concierge like REI
Right.
clinics in their market, like,
Right. Right.
but they're a preeminent academic though, so like they have kind of the latest and greatest thinking about what's going on from a research lens, so they do have a differentiator about themselves. So it'll be a fascinating project if I get it, just because I'm diving into something kind of nuanced and a little
Yeah,
more blue ocean thinking.
that is really nuanced because I was around when there were private offices. Doctors had their own private offices. And there was this big, when the big healthcare systems came in to buy up all these private offices, right? There's still doctors wanting to have their own private office, right? And so now I think the big corporate medicine has kind of bought up a lot of that. Um, and, there's pros and cons to it all, but there was a big fight against, we don't
Yep.
want to be bought out by the corporate, right? Um, but and so then insurance companies would not, I guess, reimburse them as much because they weren't bought out by the bigger hospital,
Yeah,
right?
your bigger hospital has a bigger negotiation
Right. Bigger
ability
negotiation. Right.
because they can say, "Hey, listen,
You pay us this, or
you
we're
pay,
going with
or
somebody
we're
else.
cutting this. We're not going to see your patients." And
Right.
the insurance companies don't like that either. So
Right.
they
Right.
have the corporate side has a bigger bargaining power. It's
Right.
like I, you know, it's not great for the individual private practice that has all the autonomy, but at the end of the day, we're in a capitalistic society, and like if you can't make the ends meet, then you can't do the job, and you need kind of big corporate to step in and do it, recognizing there's a whole host of problems there too. And I think what I really love about my job is being able to figure out how the corporate side can work. How do you like I love being able to think about going into big companies. There are really good ones and there's really bad ones, and being able to create and foster the cultures of the really good ones. The people that work in those really good places love it, and they feel secure, they feel safe, they feel upward mobility capability, they feel protected, and you can really only get that through the corporate lens. Like to have that sort of like job satisfaction and job security is if you're in a corporate setting with a really solid core culture. Um, there's a lot to be said for that.
Yeah, there is. I think there can be more done for the masses, right? With corporate, right? You
Yeah.
have a bigger bargaining chip, um, which bring a huge amount of advantages, right? Um, so I think corporate medicine gets kind of a bad rep sometimes, but realizing the benefits that it brings to everybody, right? The better benefits, the better uh,
Yep.
bargaining tools and availability. Well, this has been fun. I've enjoyed it. I could probably go on for more and more time, but I'm going to stop there. Thank you so much, Hunter Hayes. And yes, you're not the
Not the country music singer.
music, but I'd love to hear all the
Uh,
advantages you've gotten because of that.
I wish it was more. I get it all the time. I should be like, so you're gonna bring me a free bottle of champagne to the hotel room? Is that what's going? Like, no, I've never tapped into that, but I do get it quite often.
Bummer. Well, it's a fun conversation piece, I'm sure,
Yeah.
for a lot
Yeah,
of.
thanks. Thank you so much for having me. It's been a pleasure, and I hope I was able to offer a couple little nuggets of pearls out there for your audience to think about as they're, wrestling with, wanting to expand their career or think about pivoting, or how the ultrasound technician career is going to evolve. Just always welcome anyone reaching out to. I love talking about this stuff.
Awesome. Well, thanks so much. I'm sure it gave a lot of value to our audience. And so we say thank you. Thanks for your passion. I love that you're so excited about it. That really encourages me as someone in healthcare, knowing that hospitals do work with people like you, to better their offering. And we get the benefit of that. So thanks for what you do. I appreciate it.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.